Welcome to our discussion on cerebrovascular disorders. We'll focus here primarily on transient ischemic attacks and CVA, differentiate hemorrhagic from thromboembolic CVA and the management of both, but really focus on thromboembolic CVA management and prevention. Let's now talk a little bit about other cerebral events. First, looking at ischemic CVAs, which affect almost 1 million cases in the United States per year, and is a major cause of post-event morbidity and/or mortality. The non-modifiable risk factors for ischemic CVA is age, Native Americans. The risk to Native Americans is greater than other groups. Risks as well greater for men than women, and family history could pose some predisposition or risks as well. What's considered somewhat modifiable is diabetes, and the diabetes in the glycemic control on diabetes isn't necessarily correlated with a reduced risk for ischemic CVA. Modifiable risk factors definitely are controlling hypertension, smoking cessation, avoiding drugs that are thromboembolic in nature, as particularly the hormonal contraceptives, particularly in a smoker. AFib, as we discuss in the cardiovascular block, clearly increases the risk, sometimes dramatically, and so we've talked in that block about using the CHAD score. Coronary disease, also, pre-existing coronary disease increases risk, and carotid stenosis does as well. Other modifiable risk factors: hyperlipidemia, obesity, physical inactivity, sickle cell disease, peripheral artery disease, pregnancy risk. Pregnancy increases risk during the period of pregnancy and continues postpartum as well, and depression, interestingly, increases risks as well. Less well-documented risk factors, perhaps, and it's confounded by other data. One is alcohol intake, particularly 5 or more drinks a day. And then other factors are listed here, and it's less clear to the degree to which these are correlated with ischemic CVA. The primary prevention for patients reducing risk factors is the first one: patient education, including recognizing warning signs of a TIA or CVA. And then the primary prevention is going to be done almost universally in patients who have concurrent atrial fibrillation. As a review of what was covered in the cardiovascular block, we need to remember when we have patients with AFib, they are at high risk for CVA, thromboembolic CVA. And so those patients typically are stratified by their risk for CVA using one of the CHAD's scoring systems. The more common one now is the one that has more elements to it. And so the CHAD's 2 score, VASC score, is the more common modality we now use. But some of the older studies use the older CHAD score, so they're both listed here. In 2019, we've had some evolution in the thinking of what's the role of antiplatelet therapy, particularly aspirin, in preventing thromboembolic events with AFib, and it's become more debated. So the CHAD-VASC scores of 1 in men or 2 in women. There's some debate about whether aspirin has a role or doesn't have a role there. And despite the fact that there's some newer guidelines suggesting maybe aspirin doesn't have a role, there's a long body of evidence and historical practice that's used aspirin in these patients. And I think the other issue that you'll see in clinical practice is that for a patient for whom anticoagulant therapy would be relatively contraindicated and/or management would be troublesome, sometimes aspirin alone may still have some benefit as long as the risks are relatively low. But keep in mind that the role of aspirin in patients who have lower CHAD-VASC scoring has been under debate in the last year or two. There's also some of the American College of Chest Physician guidelines for patients with AFib, and their strength of recommendations as of early 2019, and they're listed in this table. So they pretty much review some of the comments we've talked about over in the cardiovascular block, slightly different format. But for the most part, we're looking at evaluating the risk for stroke, the risk for a bleed, and the risk for how long someone's in AFib, whether or not they need anticoagulation before cardioversion. And sort of the specific guidelines are sort of summarized in this table. The outcomes for the novel oral anticoagulants versus adjusted heparin in AFib are based on some larger studies that have been done over the last 15 years or so. The results and comparative results are listed here. What's interesting is that some of the studies used higher CHAD scores, others used lower CHAD scores, and the comparison with warfarin was compared to the time that the patients with warfarin were in the therapeutic range, the percent of time in the therapeutic range, and that varied as well. So the direct comparison of DOACs to warfarin is sort of confounded, and the variation we see here is in a sense confounded by what the warfarin efficacy was based on being in the percent time in therapeutic range and the CHAD score for the patients. But almost always with almost all of these situations, we see at least no worsening compared to warfarin when compared, in fact, maybe better outcomes. And for the most part, what we find is that the chest guidelines that are published every 3 years or so have, in the last series of publications, really recommended DOACs over warfarin for patients with AFib. For ischemic CVA treatment of an acute event, typically the first issue you need to do is you need to rule out a hemorrhagic CVA. So we would not give an anticoagulant in a patient with an acute CVA until at first we have ruled out a bleed, which could happen in up to a third of patients. Heparin is generally not recommended in stroke treatment. What is recommended typically is aspirin and TPA or Activase if it's within 4.5 hours of the onset of symptoms of the event. And the data is the sooner you give the TPA from the onset of the event, the better. The dilemma is that you need to know when the onset of symptoms were, and if the person woke up from sleep with symptoms of a CVA, then you have to look at when they fell asleep as potentially the onset of timing for that 4.5-hour window. We also treat these as medical emergencies when folks are coming in, for example, from the emergency room or from an ambulance service brought in with symptoms of a CVA to the hospital. The ambulance service will typically call that in and get the emergency department ready and the MRI suite ready so you can go, or a CT, and get an evaluation of imaging for that patient immediately, so you rule out a hemorrhage before we start TPA. The treatment of the acute event with TPA, there are exclusion criteria that are listed here. We also talk about these in the cardiovascular block as well, but we would avoid TPA if there's any bleeding episodes, active bleeding, recent surgery or trauma, which suggests an increased bleeding risk, or blood pressures that are remarkably elevated. Also, folks who are on concurrent anticoagulants typically are candidates for not being on TPA because the bleeding risks are greater. And then because the benefit is reduced after 3 hours, from 3 to 4.5 hours, the window is we look at data being less beneficial. So the criteria would look at avoiding that in old patients over the age of 80 or patients on any oral anticoagulant therapy. Secondary prevention of ischemic CVA are to, again, as we did with primary, reducing all modifiable risk factors, including lipid management, aggressive lipid management, carotid endarterectomy, and carotid angioplasty with stenting might be an alternative to carotid endarterectomy. Antiplatelets in secondary prevention are routine. We typically look at aspirin. Typically, a dose of 81 milligrams is what we typically see. An alternative to that is aspirin plus dipyridamole or Agronox as a possibility. And I'll tell you, in practice, we saw a lot of this a decade or so ago. I don't see as much of aspirin dipyridamole use as I had seen maybe a decade or so ago. Also, you'd find the other antiplatelet therapy. One of the agents here is clopidogrel, but you could look at any of the other agents in this group as well. And the disadvantage of clopidogrel are patients who would partially have a limited cytochrome P450 2C19 activity, and then an interaction with other drugs that affect that, particularly some of the proton pump inhibitors. There are other anti-platelet therapies as well. Plantel is one, which again, in practice, I don't think we see much anymore. A secondary prevention issue could be any of the oral anticoagulants as well, particularly novel agents. And those are often limited to patients who have AFib, or who have a mechanical valve or a prosthetic valve or any other higher risk factors for a thromboembolic event.